Mm. Food cakes. Good day, Dr. Hinojosa. Are you there? Oh, okay, you don't just want to watch, that's fine.
Hi, John. How are you?
Good, how are you? Welcome.
Thank you. It's been a while.
Do you want to be promoted to the channel or no?
I'm gonna move to a safer position and then we talk. Okay, give me 5 minutes.
Yeah, okay, we're here. We start in about 25 minutes.
Okay, nice.
Okay.
So are you there?
Hello, can you hear me?
Yeah, which has been a really sad week about Yuha, you know.
Hello, are you talking to me?
I was.
What was the question you asked?
I was telling you that it was a really sad week, especially all because what happened to Yuha.
Yeah, I know. I just talked to someone from Finland. Yeah,
Mm.
it's terrible, unexpected.
Yeah,
Uh,
that was the worst. I mean, it was really, really unexpected.
well, I think he worked too hard, but how can you tell someone not to work hard that has done it all their lives? Yeah, you know, I don't know. You get old, supposed to slow down, but I don't think he wanted to slow down. He just loved the OR. Who knows?
Most,
Who knows?
most of us are used to work really hard. And I think that's the way that we almost all of life we are working. I
Yeah,
remember he told me also Kiki told me that sometimes it's good to focus on our families and our lives. Work is important, but it's not everything. So actually, right now I'm trying to find a balance
yeah. I
between.
think we all are really. We can't. I don't know. It's hard to tell a neurosurgeon not to work hard, to stay away from the OR. It's probably serious, serious. But like you say, there's a life. There's a life. You've got to have some kind of balance. I just made a
I
decision.
think
Go ahead.
making a good example. Oralux is also making a good example. She's doing a lot of stuff by herself, doing other things, just more than ever with his art, with piano, with others to manage the pressure that we have working
Yeah,
healthy ways beside
yeah. I'm gonna start a
just
WhatsApp.
working. So I think that's important. I'm trying
You
to
know,
do that.
I'm gonna do a WhatsApp group for UHA tributes because everyone was touched in a different way. All over the
When did you
world.
come to Peru, young? When
Oh,
would you come
Peru,
to Peru?
that's right. You came to Peru, right?
Yeah, I'm working now in Cusco.
Cusco. Yeah, yeah. Did you come there? I know he went up north, I think, North Peru, didn't he?
Whenever, whenever you want, you can come here, man.
Oh, yeah, yeah,
My home is your home.
I've been to Colombia, never been to Peru. Maybe someday. I want to travel the world visiting neurosurgery groups. Like, for example, broadcasting from Peru. I'd like to go there and be there and talk to you on the screen. Hi, Farzan, welcome. Okay. Okay, I'll be back.
It's not expensive, so
Okay, I'll be back. I've got to go do some stuff, okay?
really
Painful. Is that Catherine Coe? Sean. All right. Hello, Ahmad Gull. Trying to get you in, Catherine. Oh, you don't want to be pro. Okay. Okay, Catherine, you don't have to come in. You can just watch. Okay, let me get rid of this. People will come in. It's a little scarce now, but we'll have more. Arshad, are you there?
Hi, John, I'm here.
Hey, do you want to moderate?
Yeah, I can moderate.
Yeah, please, because you're very. Do you have a camera? Do you have a camera, Arshad?
Yeah. Okay. Yeah.
There you go. There you go. You are the
Yeah.
most appropriate to moderate because you know neurosurgery and you're a cool guy.
Sure. What time they are starting?
Okay, a few minutes.
Okay,
What,
okay.
all I'm going to do is introduce myself, then I'll turn it over to Harshad to introduce James, okay?
Yeah.
And then you take it over. After he's over,
Yeah.
thank you, James. Let's have some questions.
Yeah. Okay, no problem. Yeah.
Okay, they're gonna, James is gonna do a small tribute to Yuha
Yeah.
first. So I
Yeah.
don't know what he has planned, but
Yeah. But it's a great loss for us.
it's a very sad time. Yeah,
Very sad, yeah. Very sad.
everybody all over
Yeah,
the world.
everything. Yeah. So many webinars we have done. Every Tuesday we used to sit.
South America, you know, he spent a lot of time in South America and some time in Central America. Miami, he spent some time there. Everywhere.
No, last when he was in China, I thought he's not well. That time only I felt he's not well. And then he went to Finland again. And that time I realized he's not too good. Of course,
Really?
he did few lectures after that. But otherwise, so when he was in China, he used to do every Tuesday rounds with Jua. We have done so many.
Yeah. I think towards there were signs. He fell down and dislocated his shoulder like a week or two before.
Unfortunately, we lost a gem. Wonderful human and wonderful surgeon. His technique is superb, I must say. Very fast surgeon.
Oh, okay.
Yeah. Yes, I'll be there. No problem.
Okay. And Catherine Coe's here. Catherine, you can talk, right, Catherine? You don't have to. Am I being nosy? Probably am. I'll leave you alone. Hey, James, now, Catherine, come on. I need to introduce you. People need to know you. Oh, on the subway. You know, in Japan, as Simon probably told you, Catherine, it's a sin to talk on the subway or anywhere else. I don't think it's a sin in New York. You got some wild things going on that subway. Okay. Hey.
John, James is asking to become panelist. Can you convert?
Okay, yeah, I got him. Good morning, James.
Good morning.
I asked Hashad to be the moderator, okay?
Yeah, that's great.
Okay.
Thank you.
How you doing, James? Busy as hell as always, right?
Yeah, busy.
Hi, James.
Hey, good morning. How are you?
Good morning. Great to see you again.
Yeah, great to see you.
Okay, we'll
Thanks.
start right off, James, okay? So, because I'm sure you're on a tight schedule.
Okay,
Okay, you're gonna do a little thing on UHA first?
sure. That'd be great.
Okay, you're gonna do it, right? You mentioned you might do it.
Oh, yeah. I didn't prepare. Okay, sure. Yep.
No, you don't have to, whatever you have planned, I'm not saying to do it, whatever you have planned is fine.
Yeah, I didn't prepare any slides, but I was just gonna say a few words.
Okay, that's fine.
Yeah.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach. Today we have the start of the second series of the Art of Brain Surgery, excuse me, masterclass with James Leo of New Jersey. And we have the proper neurosurgical introduction being done by a very active member of this group, Harshad Parekh, a neurosurgeon from Mumbai, India. Welcome, Harshad.
Good morning, good evening, good afternoon, wherever you are. It's my privilege to be listening to Professor James Liu, and I've been with him since many, many classes. And he's going to present another master class on brain surgery today and enlighten us by his fantastic techniques. And I must say, he's one of the finest microneurosurgery surgical surgeon I've seen in last decade. Wonderful, James. Its floor is yours. Please enlighten us. Thank you.
Thank you, Harshad, for that very kind introduction. Let me go ahead and share my screen. Can you all see my screen?
Yes, we can see. We can see.
Okay, terrific. So before I begin, I just wanted to say a few words on Professor Juha Hernesniemi. As some of you know, Professor Juha left us this past week, and a tremendous loss to neurosurgery and the field of cerebrovascular and micro neurosurgery. I just wanted to say a few words. I had the privilege of meeting Professor Juha back in 2008 or so, sort of near the beginning of my career. And I had the privilege of watching him do live surgery at a course in Little Rock, and very impressive man, technically, and a fervent student of the art. And during COVID, I also had a chance of communicating with him directly, and just from a human side, he was very kind, very encouraging, and he was always giving words of encouragement and inspiration. And I think those are some of the characteristics that I'll remember Juha for, and I think he's been an inspiration to many of us over the years, and I think will continue to be. And hopefully we can all follow in his footsteps and carry on his legacy of giving our patients the best possible outcome, and to also strive for excellence. So with that said, I wanted to dedicate this webinar session to him, in his spirit. And he was also, in addition to being passionate about aneurysms, I know he was very passionate about meningiomas as well, particularly very challenging ones. So I'll be dedicating today's lecture to him, and today's topic will be falco-tentorial meningiomas. And this is a very interesting topic to me. I've come to learn a lot about how to operate in this region and getting access to this region, largely due to my increased experience with falco-tentorial and pineal region lesions such as this. Now, out of all meningiomas, this is incredibly rare. We're talking like 0.3 to 1.1% of all meningiomas. And it's a unique location because, as you know, meningiomas can arise from anywhere that has arachnoid cap cells and dural attachments. And so the junction where the tentorium meets the falx is a very challenging one, mostly because it's also a junction where venous sinuses come together, where the internal cerebral veins, the basal veins of Rosenthal join to meet the vein of Galen and then enter the straight sinus. And also the inferior sagittal sinus also meets in this region as well. And because of its proximity to the back of the brainstem, progressive growth can cause compression of the cerebral aqueduct, causing obstructive hydrocephalus. They can have symptoms of headache, ataxia, and visual changes. And so it's very important to understand and study the deep venous anatomy for each of these lesions. And every patient will have a different pattern of venous drainage. And this is critically important because if you don't understand the pattern of venous drainage, you can run into some pitfalls. And it's always important to preserve the venous anatomy, because when you compromise the venous anatomy, that's where trouble can happen, a potentially life-threatening venous infarct. So we need to be able to select the route that gives you the best course of action. So here are some anatomical diagrams. This is a beautiful dissection from Professor Roten. You can see this shows you the area of the falx where it joins the tentorium. And then you can see how the venous anatomy is not so well delineated as you can see in textbook illustrations, but sometimes the venous anatomy is like a venous lake. You could see where the vein of Galen enters the straight sinus. It's a big confluence of veins here. And you can see the relationship to the splenium of the corpus callosum. This is the internal cerebral vein, internal cerebral veins, basal vein of Rosenthal, and then going into Galen to straight sinus. This is what we call the posterior incisura of the tentorium. And then the diagram to the right here, you can see the relationship that it's right above the pineal gland and the quadrigeminal cistern, the tectal plate. And then you have the vermis of the cerebellum just underneath this area. So you have this relationship of the corpus, the tectum, and then the entrance into the posterior third ventricle. So again, knowing the relationship of the veins is critically important. You could see this is the internal cerebral veins just below the portion of the tumor here. And it's important to choose your approach based on the relationship of the veins. Again, here is the anatomical diagram showing the relationship of the cerebellum, inferior inferior to the straight sinus, and you could see the relationship to the back of the brainstem here. And then in this diagram, you could see again, this is a tumor in the falcotentorial region. You could see the intimate relationship to the vein of Galen and the internal cerebral veins and the veins of Rosenthal. And then this shows you the traditional occipital transtentorial approach, where the occipital lobe is mobilized and the tentorium is cut. And you can get great access to the top of the cerebellum and also the pineal region just behind the corpus callosum. In this Roten diagram, you could see, again, this is the straight sinus going into the vein of Galen to the basal veins of Rosenthal, internal cerebral veins coursing under the corpus callosum into the third ventricle. And then this is where the region of these falcotentorial meningiomas will arise. It's important to remember the shape of the tentorium. It's not a flat surface, and the leaflets of the tentorium go upward. So it's like a circus tent. So it's very superior in the midline, and it starts to slope downwards as you go from midline to lateral. Here is an endoscopic view in a cadaver dissection showing the vein of Galen complex as you're going through a supracerebellar infratentorial trajectory. You could see again, these are the basal veins of Rosenthal, internal cerebral veins, precentral cerebellar vein, and then the top of the cerebellum. There's been various types of classifications of these meningiomas and largely based on the relationship to the veins. So you can have the tumors that are above the vein of Galen. This is a tumor below the vein of Galen. These ones are slightly more lateral based. You can see on this coronal, it's more tentorial based, but close paramedian to the falx, but nevertheless falcotentorial region meningioma. And here's another article by Asari showing the different types in relationship to the deep venous complex. This is the classification from Basuni, again, showing the different types, mostly in relationship to the vein of Galen, and you can refer to this as well. So these classifications generally help us understand the relationships to the veins, and from there we can choose the best course of approach. In general, we don't want the veins to be in our way when we operate. So, for example, if the tumor is above the vein of Galen complex, sometimes an approach from above is more favorable, and if the veins are above the tumor, an approach from below sometimes can be more favorable. So these are the different variations to get to this area. This is the anterior interhemispheric approach. It is a long reach, and generally you'd have to go through the corpus callosum, the lateral ventricle, and then the splenium to get to this area. The classic supracerebellar infratentorial approach is a well-known approach to get to the pineal region, generally done in the sitting position. Some of the limits are if you have a steep tentorium, can make it more difficult. And of course, the sitting position can have surgeon fatigue play a bit of role in there and as a limit, but also the feared complication of venous air embolism. And this can be fatal and at higher risk when done in the sitting or semi-sitting position. The alternative to that is the occipital transtentorial approach, where it's an interhemispheric approach along the course medially to the occipital lobes to get to the pineal region. The disadvantage of this approach is that mobilization or even some gentle retraction of the occipital cortex can result in visual loss when choosing this approach. And the course of it comes in a little bit more closer to parallel of the tentorium. And the modification for this is to come a little higher. And this is called the precuneal interhemispheric retrosplenial transtentorial approach. And this variation is a very nice alternative, which is the approach that I've been using largely for majority of my pineal region and falcotentorial lesions. is that you come in a little bit higher at an interparietal trajectory. It's in the precuneal trajectory, and you go retrocallosal, retrosplenium, and of course you could cut the tentorium to get more access, but the trajectory comes a little bit higher. And I'll show you details on how we do this. So this is the classic view you get from an occipital transtentorial approach. You can see the approach is closer to the tentorium. And so it's a lower trajectory, and you have to mobilize the occipital cortex, which can increase your risk of visual loss. And then, of course, this is the view from the supracerebellar infratentorial approach. And the approach we're going to focus on more is the precuneus retrosplenial transfalcine transtentorial approach. And I'll show you why this is a major advantage. And this is a paper we published with the Neurosurgical Atlas group a few years ago. But it really gives you a short, direct corridor to the falcotentorial region. Let's take a look at this example. This is a 60-year-old male who had this pineal region meningioma. And it started to grow after a few years of observation, and his symptoms became worse with balance, headaches, and left extremity weakness. You could see this is the scan in 2012, and then this is the scan in 2015. So you can see the tumor's larger. There's more effacement of the lateral ventricle, and he's starting to have a little ventriculomegaly. So what approach should we take to this tumor? Again, here are the features. What's unique about this tumor is that on the coronal, you see how one side is higher than the other in relationship to the falx. And this will play a role in terms of how we decide which side to enter from. And we'll go over that in a minute. The other feature here you want to pay attention to is look at where, see how steep the tentorium is? It's like a circus tent where it meets the falx. It's not a T, but more like a, anyone Star Wars fans, this is like, looks like an Imperial fighter. Imperial fighter sign, that's what I'll call this for Star Wars fans out there. So again, venous anatomy is incredibly important, venous relationship. And so I always get a CT venogram or CT angiogram in this case. The CT angiogram actually shows the venous anatomy if it's done with a good injection. I like CTAs over CTVs because I find CTAs gives you arterial information and venous information, whereas CTVs are shot in a delayed fashion and they only give you venous information. So I like CTAs. And if you can also get a conventional angiogram as well. But in any event, the principle is knowing the venous anatomy, and you can see that the internal cerebral veins are below the tumor. So if we take the principle of, hey, let's choose a trajectory where the veins are out of your way, coming in this direction is more favorable than an occipital transtentorial approach. Okay, so let's talk about the choice of approach here. Okay, so we are going to choose an interhemispheric precuneal approach. And we do this in the lateral position. And the lateral position allows us to use a retractorless approach where by gravity, the dependent parietal lobe will fall away from the falx to create that working corridor. Now, the decision here is if you have an asymmetric lesion, which side do you put on the bottom side and which side do you put on the top? And there's a lot of thought and rehearsal that goes into this. And the way I think about it is, if this side is going to be more lateral, I would want to put this side on top so that I can get, using gravity, this lateral part of the tumor to fall down in this direction towards the field. Okay. And this is the way I thought about this case. So I put the left side down and the right side up because the right side had a more laterally extending tumor. The other thing you have to think about is how do you get to this other side if it's creeping under the falx? So you have to be ready to cut the falx and do a transfalcine variation to cross to the other side. Now, in terms of positioning, we position the patient lateral, but there's a few things you want to know in terms of nuance of this positioning. I've placed the pins, 2 pins in the front, 1 pin in the back, and I reflex the bed and I laterally bend the neck so that the falx cerebri is going to be roughly 30 degrees from the floor. So instead of the head and the falx being parallel to the floor, I want to raise the angle so that the angle of the falx is about 30 degrees from the floor. And what that allows you to do as a surgeon is, if you're a sitting surgeon, which I think you should do for these tumors, is your line of sight is more natural to go down the angle of the falx. Okay. And so here we've made a coronally oriented incision, and the bone flap is going to be on the left side, and I take it across the midline so that I can, when I retract the dura, I can retract the superior sagittal sinus to gain those few extra millimeters of exposure. And it also gives you a few more millimeters of light. So this is the exposure linear incision. You can see I planned out the bone flap. So it's left side down, and this is the superior sagittal sinus. So I make a pair of burr holes anterior and posteriorly. So I expose the sagittal sinus, and then I flank it with a little bit of dura that's exposed, and then I turn the bone flap. Now I feel like this technique is a lot safer than doing then straddling the burr holes across the superior sagittal sinus. Okay, and then taking the bone flap across the midline allows you to retract that extra space. Now, in the beginning, I'll put a little retractor on the top. So I'm retracting the dura and the falx and retracting the sinus gently just to get a little bit more light and a little bit more room. If there's hydrocephalus, I'll put a ventricular drain after I open the dura directly from the dural exposure. And brain relaxation is very important. So we start to devascularize the tumor right at the junction of the falx and the tumor. You can see it's pretty hypervascular. After some central debulking, we can start to come around the tumor capsule. You can see the splenium of the corpus callosum in view there. It's anterior to the tumor on the left side of the screen. I'll put a little cottonoid patty to protect the plane between the corpus and the tumor. And now we'll begin to cut the falx. So we can cauterize the falx and start to make our incision through the falx cerebri. And then we'll use an 11 blade here. And then you can start to see the tumor on the other side. And then now that we have a corridor that gets us to both sides of the hemisphere, we can start to come around the bottom side of the tumor. There's the splenium of the corpus callosum. And again, working it in a slow incremental fashion, peeling the tumor away from the critical structures. So where the dangerous part of this tumor begins is the posterior margin. So if you remember the anatomy, the posterior margin is where the vein of Galen sits. So you want to be aware of that booby trap on the back of the tumor. And again, the preoperative imaging suggested that the tumor was invading into the falcotentorial junction. And if you see that on the imaging, you probably want to prepare for a near total removal where you may need to leave some residue at the falcotentorial junction. So now we've crossed the midline. Now I'm bringing the contralateral portion of the tumor down into the field. And I'm using a little gentle traction to bring the lateral part of the right side of the tumor into the field, and then using a suction to gently sweep the plane, to do suction dissection, to sweep the contralateral parietal lobe away from the tumor. Again, it's always important to make the tumor smaller. And instead of trying to get all of the tumor out, it's safer to break it up into piecemeal fashions as you get closer and closer to the origin at the falcotentorial junction. So now this is the critical part where you need to slow down your pace. And now I'm just trimming tumor from the falcotentorial junction. I've identified the straight sinus vein of Galen junction there. It looks just like the Roten diagram that you see here. And based on the imaging here, this is sort of where, you know, we start to make a decision here. This is where you need to use judgment and decide how much am I going to leave behind. This is the final view. You can see a beautiful view of the surgical cavity. I always use the 30-degree angled endoscope to look inside the resection cavity to ensure we didn't leave any tumor behind into any hidden corners. You can see there's the falcotentorial junction. There's the straight sinus, vein of Galen. I often will use an intraoperative Doppler to confirm the flow of the vein of Galen and straight sinus. And here you can see this was a radical near total removal of the tumor. And you can see we left a little microscopic residual here, and this was treated with radiosurgery about 6 months later. And here he is. This is immediate post-op in the ICU, and this is him at 6 weeks post-op. So he had a great recovery from this. This is a more recent case. This is a 64-year-old female who had occipital head pressure. She otherwise had a non-focal exam, but very large tumor here. You can see right at the retrosplenial falcotentorial junction. You can see it's involving the junction here and the coronal. And she's got ventriculomegaly. So she's starting to compress the cerebral aqueduct. You can see there's entirely collapsed. Surprisingly, she didn't have terribly symptomatic hydrocephalus, but what's important is understanding the venous anatomy here. So I had a very difficult time seeing where the internal cerebral veins or the vein of Galen. But if you look carefully here, you can see that the roof of the third ventricle is here. This is the internal cerebral veins, and it suggests that the internal cerebral veins are on the bottom side of the tumor, and it's collapsed. You don't really see a wide open vein of Galen and emptying into the straight sinus. So where's the vein of Galen? And does that mean that you can sacrifice it? So I would say B, we did a cerebral angiogram as well, and it didn't really show a good vein of Galen. But I just want to warn you, don't be fooled by that. Don't be fooled in thinking there's venous compromise, it doesn't exist, and you can take that structure and come around the bottom of the tumor. Because I don't see any collateral flow. There's no collateral venous pathway. So always preserve this if you see it at surgery. So we did this through, again, the lateral position I showed you. I've since tailored my incision to have more of a vertical sagittal incision now. I just think this is easier and it heals quite well. And you can get great exposure using a more sagittally oriented incision. Again, the bone flat is on the dependent side, but taken across the midline. And here we've placed an EVD. You can see an EVD was placed for the hydrocephalus. It was placed right into the surgical view. You can see there's the typical hypervascularized tumor originating from the falx here. We've mobilized the parietal lobe away, and the falx is retracted upwards with a little self-retaining retractor. And then we'll start to devascularize the tumor here. So spend some time devascularizing the tumor. So when you debulk the tumor, it's not so hemorrhagic. You can see it's quite white and avascular. So I used a microdoppler to map out where the straight sinus is. And here we're just making a cut through the falx. So we use a Doppler to mark it out. We'll cauterize the falx here. And we'll also be cutting the tentorium. So sometimes the slope between the falx and the tentorium is tricky. So here we found the straight sinus. This is what I believe to be the straight sinus. And you want to preserve the straight sinus. So this is the actual falx. It was a little bit higher. So now we make an entrance into the falx, and now there's the tumor on the other side of the falx. You can see it's dural base to the falx, going to the other side, and you can, by gravity, bring the tumor down from the opposite side. And here we're using a broader, I like to use this Penfield one. It's got a broader surface area, and for a big tumor, it's you can bring it down into the field better. And then using the ultrasonic aspirator to really debulk the tumor and break it into smaller pieces. I always recommend breaking the tumor into smaller pieces. You know, when you're working with a large mass and you're trying to roll it around, you could run into the pitfall of avulsing a hidden vessel, especially in a big tumor like this around venous structures. So you'll see that as we come around the backside of the tumor here, we're going to see eventually the vein of Galen, which I'll show you in a moment. But now we're releasing the anterior attachment of the falx here. And you can see there's a little bit of vascularity coming from the inferior sagittal sinus. And this is the opposite side of the tumor here. This is the splenium of the corpus callosum. You can see it's nice and white. Now look at here. There's a big venous structure here. Everything is displaced, so it's hard to figure out where this vein is coming from. But nevertheless, you have to make every effort to preserve it. I've left a little tiny microscopic residue you can see on these veins. You can see there's another vein that comes into view here. My feeling was these were probably those internal cerebral veins coming out of the posterior third ventricle, coming on the bottom side of the tumor. You can see there's a vein right here. So don't be fooled. This is not tumor. This is the vein. And I've left a little residue of tumor stuck to the vein. So this is the internal cerebral vein. Look at it. It goes up to the vein of Galen. This was completely adherent to the capsule of the tumor. And so if you started to bipolar the capsule of the tumor circumferentially, you would have compromised these veins and probably caused great danger to the patient. So we were able to use sharp dissection. You saw how I used the scissors to really spread and finely cut. Everything is sharp. There's no pulling with a Roten 6. You got to learn how to use the scissors. You got to learn how to slice and dice through that tumor and find those vascular structures. And you can see you preserve this vein, leave a little bit of this tumor right on the vein. No big deal. You save the patient. And this is the final view. You can see the brain is pretty much untouched. We recharge the CSF with saline. And here's the postoperative CT angiogram. Look how the vein of Galen and the internal cerebral vein, which was previously not present, is now, the flow is reestablished. So we have reestablished the venous flow. The tumor is out. And this is the post-op scan, beautiful post-op scan. You can see this is a radical near total removal, radiographic gross total, but I know I left a little residue on that vein of Galen. This one is a slightly different variation. This is a falcotentorial region meningioma that is primarily based on the right tentorium paramedian to the falx. And this gentleman had a known tentorial meningioma who was refusing treatment for a number of years and presented back to our emergency room with altered mental status, worsening hydrocephalus. You can see a large tumor compressing the back of the brainstem with ventriculomegaly. So you can see this is a laterally based falcotentorial region meningioma. It doesn't involve the falx, but it's in the region, largely tentorial based, but similar principles. So now the tumor is largely based to the right, more right than the left. And what was the rule I showed you before? I showed you that we would put the wider side of the tumor on the top and the less lateral based tumor on the bottom. But that's for the falx. When it comes to the tentorium, this is the exception to the rule. The tentorium doesn't mobilize up and down or left and right like the falx does in the lateral position. The tentorium is largely fixed. So it's easier to see the ipsilateral side of the tentorium in the lateral position to go more lateral. It's harder to see contralateral tentorium in the lateral position. So there is an exception to that rule that I mentioned. So be aware of what I'm telling you. So if the tumor is based on the tentorium more laterally on the right, which side do you want to put the patient downwards in the lateral position? You want to put the right side down this time. And I'll show you why. Again, typical falcotentorial region tumor. Do you want to do this supracerebellar, occipital transtentorial, or precuneal retrosplenial? So I like to follow the long axis of the tumor. I think this is a very comfortable trajectory, and you avoid occipital retraction. You avoid the threat of venous air embolism. I think coming in supracerebellar will not allow you to get all of the tumor out. You're going to be limited by the tentorium. It's going to be very uncomfortable. And if you try to pull the tumor down, you risk avulsing the veins. You also have to worry about where is the fourth nerve. This is a tentorial meningioma. The fourth nerve is going to be entering the tentorium as it wraps around the back of the tectum. So this is the trajectory that I'm going to take. I use this on the image guidance. I think about the window of corridor that I'm going to use. And so here I'm going to make my opening slightly lower just so I have more angles of attack from the sagittal view. Again, right side is down as mentioned, and I've converted to this vertical sagittal incision, which gives me great exposure, very easy to close, heals very well. We'll do a craniotomy on the bottom and cross the midline. This is my image guidance plan. I like to draw these lines anterior and posterior to the tumor, medial and lateral to the tumor. It gives me an idea of where to make the craniotomy, how to position the patient. This is what we teach our residents when we're doing pretty much any kind of brain tumor. So here's the video. Again, this is the approach. This is the image guidance. Okay, so there's often these arachnoid granulation adhesions to the falx and to the parasagittal dura that you have to investigate and interrogate and then eventually divide. This precuneal trajectory tends to be free of bridging veins. There's rarely a bridging vein here that's in your way. So it's a nice venous-free corridor. You don't have to risk injuring those bridging veins. So we're opening up the inner hemispheric fissure here. We've gotten down to the falco-tentorial junction, and I'm using a Doppler to map out the straight sinus. You can see this is the falx, this is the tentorium. So I'm opening up the right tentorium, just lateral to the straight sinus. And as I'm opening the tentorium, you can start to see the tumor expose itself here. And remember, exposure is always done in an incremental fashion. You know, as you work on the tumor, you get a little bit more exposure, dissect a little bit more tumor, a little bit more exposure, bring the tumor into your working field. And by doing that, I'm lifting the tumor up from lateral to medial and then sweeping the parietal lobe from medial to lateral. And this is how I can bring that tumor into the field. It's often adherent to arachnoid membrane, so we cut on the arachnoid directly on the tumor capsule, and this allows me to undress the tumor. There's a layer of arachnoid that's very adherent to the tumor capsule, so if you cut the arachnoid, you could start to peel the arachnoid off the tumor. We undress the tumor. It's like peeling an onion, and then putting a cottonoid to separate the tumor from the parietal lobe. Now there's the splenium of the corpus callosum. You can see there's the corpus callosum there anteriorly. And now we're working at the tentorial falx junction. We have yet to see the vein of Galen here, so we're still looking for the vein of Galen. And so you can see this tumor is rather fibrous in some cases. So now I'm using the sonopet actually to cut the tentorium. It's actually a great tool to cut through thick parts of the tentorium and able to eventually free up the tumor here. And you can see we've now removed the tentorial meningioma. And look at here, there's the vein of internal cerebral vein. There's the vein of Galen going into the falco-tentorial junction. There's a little bit of venous bleeding here. Just gentle packing with gel foam does the trick. And then you can see a beautiful resection cavity. There's the fourth nerve coming around the back of the brainstem. We saved the fourth nerve as going into the tentorium. And a gross total removal here. And we were able to save the vein of Galen. So there again, there's the vein of Galen on the endoscopic view, and here's the post-op scan. Sometimes you can have tentorial-based tumors, and these patients, when they recur, sometimes they recur in the pineal region. And this was not attached to any falx or any tentorium. And this is what we call a velum interpositum meningioma, because the velum interpositum is the layers of the arachnoid that form the roof of the third ventricle. It's where the paired internal cerebral veins reside between the layers of the telochoroidea. So the telochoroidea has an upper layer and an inferior layer, and the space in between is called the velum interpositum. And that's where the paired internal cerebral veins reside. And so you can have meningiomas that grow there that are not attached to any falx or any tentorium, and it's purely from the arachnoid cap cells of the arachnoid of the velum interpositum. Now you can have primary velum interpositum tumors where they grow de novo from there, primary tumors, but you could also have secondary recurrent tumors where a previous meningioma operated on elsewhere had seeded the velum interpositum and it's growing from there. So that's what this tumor is. You can see empty space here in the tentorium. This patient had a tentorial meningioma removed in another hospital many, many years ago, and then started to have this velum interpositum growth. You could see there's a satellite tumor here, a small little satellite, and another satellite tumor here. So clearly this was from tumor seeding. Here you can see this is the meningioma, and then there's the seeding right here. Now, when you see a dark signal on a T2 scan, what does that mean? Beware that this could mean that it's calcified or very fibrous. And that is indeed what we saw. Again, the venous relationship, very critical. Now, people have said, well, if the tumor is below the internal cerebral veins and vein of Galen, you should come supracerebellar. But is supracerebellar a good approach here? Look how steep the tentorium is. And if you do this in the sitting position, you'd have to mobilize the cerebellum all the way down below. Look at this pre-central cerebellar vein here. I'm not sure supracerebellar would be the most favorable, at least not in my hand. But instead, coming in posteriorly through a interparietal trajectory, almost an occipital transtentorial combined with a little bit of parietal trajectory. And this is indeed what we did. And we used, again, this vertical sagittal incision. Okay. And so here we've already made the faults. There's the venous structures here we preserved. And after adequate debulking, look how firm and fibrous this tumor was. But after dissecting around all the critical structures, we were able to mobilize and remove this tumor here. I was able to get some of those satellites along the tentorium, but then there were some really small ones that were hidden from my view and I missed. And we ended up treating those small little pearls with radiosurgery. But a great resection you could see here. This is the vein of Galen complex. This is a beautiful view of the resection cavity. And again, this is the view of the posterior third ventricle. This is looking into the back of the third ventricle. The tumor was sitting right into the back of the third ventricle. And here you could see a gross total removal of that large tumor there. And I want to mention this approach. This is an approach that I don't generally perform anymore, but one of my early falcotentorial meningiomas, I used this approach. And this is called the combined bioccipital, suboccipital transsinus transtentorial approach. This was described by Professor Shekar, where you get exposure above and below the transverse sinus and the torcula, and you transect the transverse sinus to get access into both supra and infratentorial spaces, and you cut the tentorium after you cut the sinus to get this exposure. And I only mentioned this out of just for academic reasons, but after gaining more exposure of the retrosplenial precuneal approach, in retrospect, I believe I could have removed this through this approach now that I've understood this approach much better. But in any event, I want to show you this case. This is a 61-year-old female. She was presenting with this hydrocephalus. She had a ventricular drain placed. And looking at the imaging here, this is a pretty large tumor occupying both supra and infratentorial spaces. And so here we did we went through the thought process of interhemispheric biparietal, occipital transtentorial, supracerebellar. And then we used a horseshoe skin incision, which gave me great exposure to above and below the tentorium. Here's the torcula mapped out with a stealth. And we did a 2-piece bone flap. We removed this large piece here and then a second piece here so that we didn't have to cross the transverse sinus. And this is the dural exposure. And so we now will monitor the pressure by putting a clip on the transverse sinus and then putting a needle, butterfly needle, in the transverse sinus proximal to the clip. So we transduce venous pressure. And you have to clamp for roughly 5 minutes and you want to see if there's a rise in the pressure, and if there's any changes in the SSEP, or if there's any cerebral edema. So there was no cerebral edema, no changes in SSEP. And so because of that, we felt it was safe to go ahead and divide the transverse sinus and then cut the tentorium to get this exposure to the tumor. And here's the exposure. So we now cut the tentorium now after ligating the transverse sinus and dividing it. And there's the tumor. We start to expose the tumor here. Working in the lateral position, debulking the tumor with an ultrasonic aspirator. And then performing extracapsular dissection. And there's the trochlear nerve. There's the back of the brainstem. There's the trochlear nerve. You have to preserve these fourth nerves to prevent vertical diplopia. There's the basal vein of Rosenthal. It's starting to become a bit adherent to the vein, so we have to be a bit careful. There's the internal cerebral veins. There's the vein of Galen. There's some adherent tumor there. So this is where you have to make a judgment call and start to be conservative. And, like one of my former colleagues used to say, better to leave a little bit of tumor on the vein than the vein on the nerve, than the vein on the tumor. Better to leave a little tumor on the vessel than the vessel on the tumor. So we trimmed the tumor, left a little tumor on the vein, and there you could see little residual on the vein of Galen complex, but overall, I felt this is a very satisfactory resection. Decompress the ventricular system, you could see restoration of the flow through the third ventricle or through the cerebral aqueduct. Here's the post-op scan, and post-op scan. So in conclusion, falcotentorial meningiomas are quite fascinating, very challenging, and they can be accessed through an interhemispheric approach, lateral position, gravity assisted, no brain retraction, and very important to preserve the venous anatomy. And using the endoscope is very helpful, looking around the corners and inspecting for any residual tumor. Thank you very much. I'd be happy to take any questions.
Thank you, James. Excellent, wonderful demonstration of falcotentorial meningioma excision. I'm really impressed with your approach of precuneous transtentorial and interfalcine approach. Wonderfully done and superb. I agree with you that many times it is not easy to approach these tumors from supracerebral infratentorial approach because of the location of the veins. And yes, meningioma surgery is a preservation of the veins. If we know the venous anatomy and if we can preserve the veins, then we have achieved a lot of competence on the removal of meningiomas. If we damage, we have lost the patient with the either we have a mortality or a morbidity. So it's very important to understand the anatomy of the veins. And this approach is really wonderful. And your positioning is superb on the lateral side and giving your gravity down so that you can approach the tumor. The grade 1, Simpson grade 1 excision is not always possible. Many times I have seen these meningiomas are stuck to the veins. We don't want to make a hole in the veins while separating this, even though there is always an arachnoid plane, but at times it becomes difficult. And in my experience, I felt it is wiser to leave a bit of tumor there rather than going for a total excision and ending up with some issues. So Simpson grade 1, every time you cannot get in this kind of lesions which are deeply situated in the midst of the veins. You got bilateral internal cerebral vein, you got a vein of Rosenthal, you got a vein of Gallen there, straight sinus, inferior cerebral, and you have to preserve all these things. And you have shown it wonderful technique, absolutely fantastic. And yes, meningioma is really a fascinating surgery for any surgeon. Like an acoustic, I feel this is something worth understanding. What is your experience if it is a tentorial meningioma on the one side coming into the posterior fossa? How do you tackle? Would you come suboccipital or you will go supracerebellar?
Yeah, that's a great question. I've done them both ways, and it really depends on each individual case. It depends on where the tentorium, the tentorium is such a broad structure, and some of them are more anterior tentorial, some are more posterior tentorial, some are more medial tentorial, some are lateral tentorial, and I don't do one single approach. Every case is individually different, and maybe that is a lecture I'll prepare someday in the future. But I've done the whole spectrum of approaches of anterior petrosal for a medial tentorial meningioma. I've done supracerebellar transtentorial for some tentorial-based meningiomas, and I've also done subtemporal, sometimes even slight transcortical to get the right corridor trajectory to it. So it's a number of approaches you can do. And I think the beauty of these is that the whole idea is you want to have a whole armamentarium of approaches to choose from and not be limited by a single approach, and choose the best one based on the individual features.
Harshad?
Uh,
Hello, Harshad, yeah?
You're muted,
Hello.
Harsha.
Yeah. I have tried to remove this suboccipital by doing a suboccipital craniotomy supracerebellar. And I found it very good approach to go around. But when it comes to going towards the tentorium, and the most of the supply is from the tentorial side, and while separating, many times the bleeding starts. And when a bleeding starts, it keeps on dropping on your field, and it becomes very difficult to control that bleeding from the tentorial side. So is it wiser to come from the above rather than going from the supracerebellar in such cases?
Yeah, I think you can do them both ways, right? So the advantage of coming from below is that if you're attacking the tentorium, you're cutting off the blood supply early. The worry is that if you run into a venous lake, sometimes it's more challenging when you're on the suboccipital side. And then if you came from the supratentorial side, you're seeing the tumor capsule first, but you can still devascularize. If you find the tentorial edge to the tumor, you can still devascularize it from the base and start amputating it from the base. But I don't think there's any right or wrong answer. Each individual case is so different.
Right. Thank you. There is one question on the chat box, Q&A, where you specifically use intraoperative monitoring in falcotentorial meningiomas.
Yeah, I typically do somatosensory and motor evoked potentials. And you can also do fourth nerve monitoring as an option as well. But those are the main modalities. And then I'll do ABRs also just for brainstem monitoring.
Thank you, James. Wonderful. Any questions, please ask.
Don't be shy. Audience is quiet today, Harshad.
Okay, but the lecture was awesome, wonderful pearls of wisdom he has given, and we have taken it in a lot of understanding. He has given a lot of good understanding, James. You have given wonderful talk. Thank you very much.
Okay. Yes, James, thank you very much. And we'll stay tuned for part 2 of the second series of your presentations. What is next week, James? You have the title yet?
I don't have the title yet, but I'll be happy to email you
Okay.
the title. Yeah.
Okay, James.
Okay.
Everything all right, James?
Yeah, no, everything's good.
Okay, great. Thank you.
Yeah.
Thank you, James.
Okay.
Thank you. Thank you. Thank you. Wonderful.
Thank you, everyone.